Hi everybody, nice to be here. So that's me, Dr Charlotte Tottman. I'm going to talk to you today about what it's like to live with metastatic breast cancer. Seems a bit silly to be saying that to people who are in fact living with metastatic breast cancer. It's like, what can I tell you? I'm going to talk to you from three perspectives. From the theory of psycho-oncology. So psycho-oncology is clinical psychology that's about dealing with cancer-related distress. So it's just sexy language for cancer stuff. I'm going to talk to you about it from the perspective of my clinical practice and from my own personal experience. I don't live with metastatic disease, but both my parents died from cancer, mum from ovarian and dad from bowel when I was in my 20s. And so I guess as a family member, I've had that experience of navigating that with them. I also treat a lot of patients. I do only cancer work, so I consult 3 days a week, 10 sessions a day, so I see 30 clients a week, and it's all cancer work, and a lot of those people are living with metastatic disease. And I want to just pay tribute to Dr Andrea Smith, who's one of the key members of BCNA, who does a lot of work and has done a lot of work with Vic around the metastatic numbers. And when I was doing the podcast, one of the episodes on the podcast was about living with metastatic disease, and Andrea and I spent quite some time working through her own lived experience, and I've drawn on that a lot in terms of what I talk about today and also in the podcast series. They're my contact details if anybody wants to get hold of me. If you get to the end of this and you haven't got that, you can always just put my name into Google and I'll pop up. Before I go any further, the stuff that I talk about today can be triggering. I'm not a touchy-feely psychologist. I'm not very zen, I'm very direct, and it does mean that I talk fairly candidly and fairly quickly about a lot of stuff that can push some buttons. So if you get to the end of the day and you feel like, whoa, that was a lot, then do take a moment to just debrief with someone that you trust. Might be a trusted family member or a friend, might be your McGrath nurse, might be your GP, but just do take the chance to debrief if it's pushed some buttons for you. So I use this analogy to just explain why sometimes living with metastatic disease can kind of rock your emotional, psychological stability, and it goes like this. It's a stool analogy, not that sort of stool. If you think about the seat on a stool as your mental health or your psychological well-being, usually it's supported by a number of legs, at least 5, sometimes more. And those 5 are often these: family, friends, hobbies and interests, work or volunteering, physical health and healthy lifestyle behaviours. So what happens when you're living with metastatic disease is quite often the legs on your stool start to disappear. So your stool or the seat on your stool or your psychological well-being starts to become less stable, starts to tip. So if you feel like at any time that you're struggling psychologically, there's probably a really good reason. Stuff that you used to be able to kind of rely on and use to support your well-being is often stripped away or impeded by living with metastatic disease. These are the things I'm not going to talk to you about today, okay? This is the talk, this stuff that I'm coming up with next is the stuff that I'm going to talk about in the next hour next door. But I want you to understand that I'm deliberately telling you what I'm not talking about with you because I want to make that distinction between the fact that it is different living with metastatic disease. These are the sorts of things that I talk about when I'm talking to people living with early breast cancer. So very quickly, diagnosis shock, emotional isolation, which is that feeling of they just don't get it, relationship issues, body image concerns, a big perspective shift, which can be like figuring out what matters and what doesn't, post-treatment adjustment difficulties, which is when you kind of come to the end of hospital-based treatment and what happens after that, and fear of recurrence. Now, for those of you who were originally diagnosed with early breast cancer and have gone on to metastatic disease, I bet some of that stuff is familiar. For those of you who are diagnosed de novo metastatic, that might be stuff that you're already dealing with now, or it might not really resonate. I'm not going to talk any more about that. Common psychological issues in a metastatic breast cancer experience is what I am going to talk about, and they're these 4. The metastatic spectrum, living with uncertainty, fear of disease progression, and mortality. You can see just by those titles, this is big stuff. Yeah? So if it's making your heart rate go up or if it's making you feel a bit teary, I get that. In my work, I ethically I have to go to these places. If people come to see me, we are going to talk about this stuff. It is not comfortable. It is not easy. But it does help process hard stuff. It helps with adjustment. It helps with confronting things that a lot of people in your life might not want to talk about. So the metastatic spectrum is this concept that I came up with when I started to understand that there's a very, very broad range of presentations oncologically that can all be described as metastatic disease. For example, you can have one bone met, well managed with some occasional radiation therapy and some hormone blocking treatment. You can have that all the way through to end stage metastatic disease where the end of your life might be approaching in weeks or months, and everything in between. And all of those presentations is called metastatic disease. That's pretty hard. It's pretty hard to get your own head around that. It's pretty hard for the people in your life to get their head around that, because there aren't kind of different descriptors to describe these different presentations in oncology. One of the things that often we do as humans is we compare. So if you are living with metastatic disease, and you probably then know other people who are living with metastatic disease, sometimes you can fall into the trap of comparing your situation and theirs. And because we're human, and because most people are good people, we often compare in a way that makes ourselves feel bad about the fact that maybe I'm getting off lightly. You know, I've only got bone mets, or I've only got to have hormone treatment, as opposed to going, my situation is really hard, their situation is really hard, it's not a competition, nobody's winning or losing here, this is just hard. Comparisons can mean, when we find ourselves feeling like somehow I'm less than, I'm fortunate, it can mean that we do this thing called invalidating our own experience. And that can mean that we're not really allowing ourselves to process the magnitude of what it is we're going through. And that is really important. Emotional isolation, as I mentioned before, is this concept where you can feel surrounded by people who really love you, and they can demonstrate that they love you and care about you, and you can know that absolutely, you know, fully to your bone marrow, but you can still feel like, even with all of that love and support, that they just don't get it. They just don't know. I have a magnificent husband. He's a clinical psychologist. He probably gets it as close to another human being can get it without having cancer, but he still doesn't get it. Not in a bad way, not in a mean way, not in a way that he intends to not get it. And he's nearly there, but there's always this gap in his understanding of my early breast cancer experience. And it is a thing that I think we struggle with, particularly because if you're on a desert island and you're literally on your own and you feel emotionally isolated, it makes sense, because it's like, I'm looking around and there's no one here, so of course I feel isolated. But if you're surrounded by people who obviously care about you and obviously love you and have your best interests at heart, and you still feel emotionally isolated, that can be incredibly confusing. And it can also make you struggle with the fact that, like, I feel a bit cheesed off, or I feel a bit like I'm a bit intolerant or a bit snappy, but I can't really express that easily because I'm getting all this kind of love stuff, but I'm still not getting the feeling that they really know what it's like to live this life. So this is why I say empathy is gold, go where you're understood. And that's where things like these sorts of forums, BCNA, the helpline, the online networks, anywhere where you can gather in person or online with people who are going through or have been through something similar. That feeling, it really is best described as, like, you know it when you feel it, like when someone just gets it. It's almost like a shorthand. I can imagine that there are people in this room who can talk to one another and you don't have to explain or educate or persuade. It's like you can see in the other person's eyes reflected back that they get what you mean. You don't have to talk about a lot of the cancer stuff because you know that they know it. You can talk about other stuff. Whereas I think when you feel emotionally isolated, sometimes there's this thing of like, oh, I've got to keep kind of telling other people and almost convincing them of what it is like to live the life that I'm living. Bittersweet is a descriptor that I think is very apt in the metastatic space. It means that every important event in our life that used to just have one meaning now has more than one meaning. So things that are joyful sometimes take on another meaning because we start to feel like we're not quite sure how many of those joyful experiences there might be left. Special birthdays, special moments with loved ones, grandchildren, milestone life events, even very small things can make you just go like, how many more of those fabulous sunrises am I going to see? So there's that real edge to things. And I think that, again, for people who aren't living with metastatic disease and are full of the positivity and wanting to just be incredibly positive about everything, I mean, sure, that's nice. It's a nice idea to be positive, but I think it's really important to acknowledge that there is sometimes like an underbelly to even the joyful and positive things. Gratitude fatigue is this concept of like when I think I've had a lot of clients express, it's like people say, oh, you're so lucky, you're so lucky they caught it, or they caught it when they did, or you're so lucky that you've got such a great medical team, or that you've got that drug, access to that drug. And it's like, yeah, sure, all of those things are true. And being grateful for those things and appreciative of those things is, of course, appropriate. But a lot of it doesn't really feel all that lucky or fortunate. And sometimes, again, it is important to just be able to go, I don't feel that friggin' grateful. I don't feel that friggin' lucky. And sometimes I just feel really a sense of injustice or a bit robbed, a bit pissed off. And that why me thing, we can do the, yeah, why not me? And that is absolutely true. And most cancer is mostly random chance. But occasionally it's good to kind of like down the gratitude and just go, you know what? Some of this really sucks. The thin pink line is a concept that Andrea and I talked about, which is where she was saying to me, Andrea's a PhD, she's a super smart woman, she's very capable, but she's had a number of recurrences in her metastatic journey, and she was describing to me how frustrated and surprised she has felt on repeat each time she's had another disease progression. She's kind of got her mojo back after a period. She's kind of got back to doing some work, kind of got a bit of a rhythm going, a bit of routine, feeling strong again, feeling well again, and feeling like her coping has got a bit deep, like there's a bit of capacity there, there's a bit of buffer there. And then she's been really frustrated and disappointed when she's had another disease progression and she's felt like what she thought was about that thick was actually about that thick, and that she's plummeted from feeling pretty good to pretty dreadful pretty fast. And you don't rebound from that stuff fast, you just don't. I mean, we talked about whether you get better at it, and I mean, I think all humans learn from every experience, but it's really hard coming back on repeat from disease progression. Living with uncertainty. Humans don't like uncertainty. We like to know what's going to happen. That's why COVID threw the world into such a tailspin. It meant that we were all dealing with a situation that was unfamiliar, uncertain, unknown. We didn't know how it was going to unfold, how it was going to affect us in the short, medium and long term. Living with metastatic disease is about living in a puddle of uncertainty. When we are dealing with uncertainty, it means that we don't have predictability. When we have predictability, when we know what's coming, we can forecast, we can plan, we feel secure, we feel safe. When we don't have that, then we have an increase in anxiety. So for a lot of people living with metastatic disease, their baseline anxiety is just higher all the time, all the time. I say that we're living with metastatic disease, there's no innocence. When for those people who were originally diagnosed with early breast cancer, it's like at that point you're sort of protected by your innocence. You don't know. You don't know what's coming. You don't know what treatment's like. You don't know what the appointments are like. You don't know what can happen. And sometimes that's quite nice. But when you're living with metastatic disease, most people are experts by then at cancer. They do cancer. They know cancer. They're experts at the terminology, about how to manage the medical system, about how to navigate things with their treatment team, with their friends and family. And having that knowledge is obviously helpful in one way, but it also means that you know what stuff means, you know how this could go. And so there is no protective innocence. Sometimes, I'm sure meant with good intent, other people not living with metastatic disease will say things like, oh, well, You could always get hit by a bus. And I think, yeah, but living with metastatic disease isn't really like that. In my mind, it's kind of like you're standing in the middle of the road, you know? The odds go up. Living with metastatic disease is not like you could be hit by a bus. So how do you reduce uncertainty? You're not in control of what happens with your cancer. You're not in control of how your body responds to different drugs. You're not in control of what side effects you might get. But you are in control of some of the stuff that you can do about the life that you're living. I am big on having the tough conversations. One of the things about living with metastatic disease is that you can live a really long time with metastatic disease, and a lot of people can live not a bad quality of life with metastatic disease. But I think you all appreciate that there are plenty of examples where that's not the case, or where things can change and they can change fast. When people are feeling pretty well and responding well to treatment, there is a pretty understandable reluctance to have the tough conversations, because it can feel like, why would I want to make myself sad or distressed or think about what could come further down the line or put my family and friends through that? Why would I do that to myself, Charlotte? And I say to them, well, because when you're feeling well, you've got capacity, cognitive, emotional, psychological. You've got capacity to have those conversations. You've got capacity to talk to your lawyer, to fill in forms, to sit and think and feel and write. If something happens and things can change quickly, you can suddenly find yourself without that capacity. It's too hard, you're too medicated, you're too sad to do that important work that needs to be done. Having the tough conversations can be incredibly uncomfortable, but incredibly rewarding. It can give you the opportunity to say, express in writing or words what other people mean and matter to you, but also to give them the chance to say things back. And if you kick that can down the road too far, sometimes you never actually get to do this. In the work that I do, I have the privilege of watching this unfold with families. I've seen every version of this. I've seen where people don't do it at all. I've seen where people try to do it but do it too late. And I've seen where people do it early. And I tell you 100%, when they do it early, the burden on the family and the burden on themselves when the time comes is so greatly reduced. So even though it will feel uncomfortable and counterintuitive to go into that space when you're feeling good, if you wait for the day for it to feel comfortable, that day will never come. If you have people that you love, it is a gift to them to have those conversations. Dealing with personal admin, very dull, can be hard because writing things down or getting forms filled in by your medical team can be incredibly confronting and challenging, but it can substantially increase the chances that your wishes are in fact what happens. If you haven't ever said or written down what you want to happen at the end of your life or after you are gone, then there is a pretty good chance that might not happen, or that people who love you will argue about it. If you're clear about it and you communicate it, then you can feel a sense of relief because you actually managed to convey that and you can have what you want, but you also then relieve your loved ones from having to think or make those decisions. They can be sure that then they're doing what it is you wanted. So a lot of what I've just talked about then applies to this. Managing the risk of regret is sometimes about having those hard conversations and dealing with personal admin. It can give you a sense of relief because there's the knowledge that what you want is actually going to happen, but you can give you the sense of relief that you've taken a burden off the people you care about. It increases certainty because instead of wondering like, how is this going to go or what's going to happen when, you can actually increase the chances of exactly what does happen. And when you express it, sometimes doing it verbally is really too hard. You don't have to say it. You can write it down. You can also do things with people. You can go to places, you can visit a palliative care hospice together, you can do things together that can actually make these things a little bit easier than just sitting down and having the eyeball-to-eyeball conversation. Regret is a nasty emotion because it's based on things that we can't change. Getting to the point where you might be struggling with the advanced stages of metastatic disease and dealing with regret, that's not helpful and not necessary. There are things you can do in advance to reduce that risk of regret. When you're dealing with uncertainty, one of the things that can offset that feeling of the struggle with uncertainty is to increase perceptions of control. And you can do that by setting short-term goals. Usually when I think about short-term goals, it's something where I can almost see the end of it before I start. So it might be a goal that might take maybe 3 months to complete. It should be a goal that has some kind of relevance to you, some purpose and meaning, and it should be small rather than big. Now, the thing about goal setting and little projects is it's very individual. What's going to work for me is probably not going to work for somebody else. Depends on things like, how mobile you are, what your hobbies and interests might have been, whether it's easily accessible, how much money it costs, how much time it takes, and it is very different. Lots of people that I see will do things that tie in good feelings. So it might be things like scrapbooking, because you're looking at photos and memories. And the thing about photos is they're almost always taken of times when they're good times. People are smiling and it generates like positive vibes and oxytocin in your system and good stuff like that. Craft activities are fantastic, really good, because you can often do them if you're a bit physically incapacitated. When you're engaging in craft activities, they're high attention to detail, which means you can't usually be doing too much else with your brain or your heart when you're doing craft stuff, and you can produce things that you can share with other people that can be really lovely. They can also be things that you can do with other people, so loved ones, families and friends. So those sorts of things are good to do. Focus on what you can control versus what you can't control. Like I said before, there's a whole bunch of stuff living with metastatic disease that you're not going to be in control of. Recognising what those things are and shifting your attention away from those onto the things that you can control increases perceptions of control, gives you back agency and gives you the feeling of being empowered in a situation where you can often feel disempowered. Fear of disease progression. So with early stage breast cancer, we talk about something similar, which is fear of recurrence. Fear of disease progression is obviously the fear that the disease is going to progress. There are 2 common responses. So fear of disease progression is a very specific anxiety. It sits under the umbrella, a bigger umbrella of anxiety. All anxiety responses in humans fall into mainly 2 categories behaviourally. One is avoidance, which is staying away from things that make you feel uncomfortable, and this other one is called reassurance seeking. So reassurance seeking is seeking to elicit from others, circumstances or events the idea that everything's going to be okay. So some people do avoidance, some people do reassurance seeking, some people do a bit of both. What's interesting to me is that I see in early breast cancer, I see a lot of reassurance seeking. A lot of people in early breast cancer who have fear of recurrence, they want to go and have scans, they want to go and have more medical checkups, more medical reviews, they want to get that regular reassurance that everything's okay. Interestingly, in metastatic disease, I see more avoidance. Not always. Some people do a bit of both, sometimes it's the other way around. But my theory on why there's perhaps a bit more avoidance, so sometimes people will go, I've got a new pain or I've got a new symptom, but I'm actually putting off going and getting it investigated because of that lack of innocence, because of their knowledge already about what they might be dealing with and what they fear might come as a result of going and getting that particular symptom investigated. It might mean evidence of disease progression. It might mean a change in treatment protocol. It might mean something more serious than that. So it's an interesting space. What I encourage people to do is be aware of their tendency towards avoidance or reassurance seeking. Reassurance seeking is one of those, I'll give you a couple of examples of it. So reassurance seeking can come in very many forms, nothing to do with metastatic disease. But if I say to someone, do I look good in these jeans, dear? That's an example of reassurance seeking. I'm trying to get someone to tell me that, what I want to hear, essentially. But reassurance seeking in oncology is often about, I want a scan, or I want bloods, or I want someone to do a physical review. Try and figure out, am I more an avoider or am I more of a reassurance seeker, or maybe when do I do one or the other? And just be kind of conscious of it. If you're getting to the point where your avoidance or your reassurance seeking is creating another problem, so if your avoidance is meaning that actually you're starting to feel worse physically, then that's a sign that maybe your avoidance is, your anxiety is in the driver's seat, because your anxiety is dictating the avoidance and then it's creating a bigger problem. If it's that it's reassurance seeking and you're going back to your doctor so often, the problem with that is you can develop this boy who cried wolf kind of situation, where the doctor starts to get frustrated because they feel like they're being asked to provide reassurance when there's no clinical indication for that. And the risk of that is that when there really is something, that no one's really paying enough attention. So it's a good thing to just tune into. If you notice that you're feeling fear of disease progression and you feel like, I can't get rid of it, then you'd be right. Fear of disease progression and fear of recurrence are things that are normal responses to an abnormal situation. A lot of surgeons and oncologists say to me, Charlotte, how can we get rid of it? And I'm like, well, I'm going to disappoint you, because the literature tells us that it is something that happens usually during and after treatment, and it persists for the rest of our lives. It's not usually triggered all the time, but it sits like in the back blocks of your brain, and every so often there will be a trigger. Sometimes the triggers are around physical symptoms, sometimes it's around a medical review or the death or diagnosis of a friend or a family member, sometimes it's around anniversaries. There are lots of triggers, and so it will spike and then it will settle down. When people say to me, well, if this is going to be kind of part of my life, then how do I deal with it? I thought about it a while ago and I thought, well, what do you do with something if you can't get rid of it? You try and find a way to make it work for you. So I think using fear as a motivator is one way to make it work for you. Using fear as a motivator in the metastatic space can be about things like healthy lifestyle behaviours. So it's like about, how do I look after myself the best? You know, how do I eat a good diet? How do I get enough sleep? How do I do enough mobility stuff? And how do I engage in activities with purpose and meaning? They're the 4 pillars of coping. So motivate yourself to do that. But also, how do I make the best use of my time? If there's a chance that the quality or the quantity of my life could be further compromised, then I've got to crack on and I've got to get on with my living, do the stuff I want to do. Don't wait, get into it. Mortality, big one, yeah? I call it the darkest of places. When people say to me, Charlotte, I've been thinking about death and dying, and then they say to me, like, what's wrong with me, or how do I stop that? I say to them, it's an incredibly normal thing to do. In fact, if a person who had been diagnosed with metastatic disease hadn't on occasion thought about death and dying, I would think that was rather odd. It is a very reasonable thing for your brain to entertain. However, it is a place you want to visit. You don't want to stay there all the time. So I say to people, if your brain takes you there, you know, for a few minutes every week, I have no problem with that. If your brain's taking you there for a few minutes every hour, I do have a problem with that. I have a client who is not living with metastatic disease, but she's a good example of this. She said to me, I've cut back my work and I'm spending my time making healthy lunches for my teenagers, because when I die, there isn't going to be anyone there to make the healthy lunches. And she's not going to die, certainly not anytime soon. And I said to her, if you want to make healthy lunches for your kids because you want them to be healthy, I have no problem with that. Make as many healthy lunches as you like. But if the only reason you're in the kitchen working less is because you're convinced that you're going to die, that isn't the right reason to be making those healthy lunches. Do you get the difference? So it's about understanding that it's okay to go to that mortality place, it's okay to entertain death and dying, but it's also about not letting that be the driver for every single part of your life, because then it's almost as if you're dying before you're dead. Get me? In my consulting room, I have a small blue couch. It seats 2 people. A lot of the time I have clients who from time to time bring in a partner. Often it's women who bring in a husband, sometimes for 1 session, sometimes for more. And we often have those sessions around metastatic disease and quite often around death and dying, mortality discussions. I have lost count of the number of times that I've had husband and wife sitting on the blue couch and I have said to, and no disrespect to the blokes here, but I've said particularly to the guys, because by this stage in proceedings I've usually had a fair bit of talking around mortality with my female clients. But there will often be a real reluctance in husbands or partners to go to that space. And I have lost count of the number of times I have said, do you think that if we start talking about death and dying, that if we start mentioning words like mortality, do you think that that is going to increase the chances that it happens, or that it's going to increase the chances of increase the speed with which it might happen? And I have had professors of medicine sit on that couch and say, yes, I do believe that. Yes, I do. I think that if we start talking about it, it's almost like we let death in the room. Now, there is no scientific basis for that. So it's a superstition, but it is a superstition that is widely held, and it is one of the reasons that I think in Western culture we don't talk about death and dying, because there's this sort of like voodoo thing around it of like, if we start talking about it, it's going to happen. If it was that easy, my mother-in-law would have died a long time ago. But it's not like that, you know. We don't have that power to cause people to live or not live just because we talk about it. One of the things that is a common discussion point around metastatic disease is the importance of hope. So years ago I was asked to talk at an ovarian cancer seminar, and they asked me to talk about hope. And because I never like to be caught with my pants down, I did a little bit of extra research before, and I just wanted to check, like, what's the point of hope? And essentially, when you look up the point of hope, it is why we get out of bed in the morning. If we don't have hope, then we don't keep going. We don't get up. We don't do anything. So hope is really important in everybody's life, but it is particularly important when you're living with metastatic disease. So I never, ever want to give the impression that we shouldn't have hope. However, with almost everything, you can have too much of a good thing. So I make this distinction between what I call realistic optimism, which is hope, and unrealistic optimism, which is denial. So if you think about hope or realistic optimism as a balloon, what I like is the idea that you're holding your balloon high. Your hope is high, but your feet are firmly planted on the ground. If you get to the point where your hope takes you off the ground and your feet leave the ground and your feet are not based in reality, the risk is that your hope takes you to a place of denial. And the risk psychologically then is that when you have to inevitably confront the reality of the situation, it is a very long, hard fall, and that's not good psychologically. So whilst hope is absolutely critical, it's also really cool to understand the distinction between realistic and unrealistic optimism. I pinched this strategy from Jackie, who I don't know, who's a palliative care nurse, but I really like it. She talks to her metastatic clients who are dealing with advanced disease about this idea of 2 lines. How you always have to have 2 lines. One line is called hope and the other line is called getting ready. And it's like they're 2 parallel lines and they both need to be activated all the time. Preferably with hope just a little bit in front of getting ready. But it's the sort of thing where I really like it, because if you've got a client who's only doing hope, the risk is they're not doing any of the getting ready. If they're only doing the getting ready, the risk is they haven't got enough hope. But if you've got both hope and getting ready going on, I feel like you're in that nicely balanced place where you're able to make the most of the life that you've got, but you're also taking appropriate steps to manage things as they unfold. Does that make sense? So in summary, your experience, don't need to really spell this out, do I, is a marathon, not a sprint. And I hope today that I have explained that there's a role for hope, that anxiety is a big part of this, that having agency or perceptions of control is really important in coping, and finding that support, that empathy, that connection is so important, particularly if you feel like there are other people around you that might not get it. Go where you're understood. Empathetic others might be friends and family, might be a GP, might be a breast care nurse, might be a therapist. If you want to listen to my voice a bit more, there's 2 podcast series that I've done with BCNA, incredibly well received, and there's 2 seasons, each 10 episodes. There's QR codes if you want to snap on them. And I'm happy to take questions.
Thanks, Charlotte. Any questions? I've got the microphone just so that everyone can hear the questions.
Thanks, I'm Jan.
Hi, Jan.
We've just had a close friend who a lot of us know who's just passed.
I'm sorry.
The realistic hope. Now, her family didn't have realistic hope. How can you convey to family members realistic hope?
As opposed to unrealistic hope?
Yes.
Yes, absolutely. It's a really good point, and her family would be among many who would be in similar circumstances. I think watching someone you love go through metastatic disease and the end of life is probably, it's different. It's a very different experience, but it's a very, very helpless experience. And human beings don't like discomfort. They don't like discomfort and they don't like distress. So if they can find a place in their brain that allows them to feel less discomfort and less distress, they will often keep gravitating towards that. And if they're not given information to challenge that, then they often it will allow them to stay in that place. So sometimes giving them exposure to the medical team, like a family meeting with an oncologist or the palliative care team, to actually have somebody who's a white coat, if you like, so not maybe another family member, maybe not the patient, but someone who's got, if you like, a medical degree or an external qualification to be able to sit and explain to them the reality of the situation. Sometimes that can help. I think explaining something like the difference between realistic optimism and unrealistic optimism, because, I mean, I hope that that was clear when I explained it, and being able to actually make that distinction for people and say, do you get that there might be 2 ways to look at this, and I wonder which way you might be looking at it. Do you get what I mean?
The point was also that family weren't in the realistic world.
Yes.
Friends were.
Yes, okay.
And, you know, you get to the point where
So
you're being a friend, you can't push yourself in.
Absolutely. And it is really difficult because the way that the medical model works too is that they will reference family before friends, and so it's like it could become almost like a circle, like a castle, where if you've got surrounded by people who don't really get it and aren't engaging, then the friends are kept out of that space, and that's really hard, really, really hard. I'm not sure when you get to that situation. So the thing about denial is it's brittle. And if you shatter denial, it's usually pretty messy. As a therapist, I don't like doing it, and I can mop up the mess. But as a friend or someone, you know, in an extended social network, I wouldn't advise necessarily shattering the denial, because the mess that it would make, and then leaving you when there's already a lot of distress going on, to then have to also mop up the mess of that shattered denial would probably not be good. So as much as I don't like saying this, sometimes if the denial is that strong, Sometimes you just have to let it play out.
Yeah, that's what we had to do.
Had to do, yeah.
Other questions? Charlotte, I think we certainly hear from people that call in or ring our helpline or speak to us about the changes in the way we treat metastatic breast cancer now, and people can live 20, sometimes we're now seeing no evidence of disease.
Yep.
Can you talk us through what that means for people living a very long time and what that means in their emotional world?
Yeah, it's tricky because it's so true, and that it used to be, decades ago, it used to be that a cancer diagnosis full stop kind of meant death. Then it moved to it could mean a change to the quality or quantity of life. And now it absolutely is that people can either fully recover or can go and live a very long and really relatively good quality of life while staying in treatment for decades. And I've certainly got clients in that camp. It's a hard space because even though that good news is real and valid, it's still tinged with that uncertainty and the fact that even as good as everything can get, there's no oncologist or surgeon who can give anyone that rolled gold guarantee that, like, right, well, where we've got you now is how you're going to stay forever. Like, that just doesn't happen. So there's a balance to be found in how do I kind of like live this sort of normal life where I reclaim maybe things like work and parenting or caring obligations and go back to doing things that I love, like travel or other things, but also kind of with one eye open to the possibility that there could still be something around the corner. It is a hard space to get used to. I see clients do better when they integrate their cancer experience into everyday life, where cancer becomes, if you drew your life as a pie chart, and cancer becomes like a slice of the pie, as opposed to a big pie out there and then the rest of my life here. So when it just becomes almost like, you know, I mean, I don't want to in any way underplay this or diminish the reality of what a big deal metastatic disease is, but where treatment and side effects and the part, you know, living with cancer becomes a bit like, and I'm a grandparent, or and I'm a psychologist, and I like running, you know, it's just part of your new reality.
Yeah, and the other question we often get is around what's the latest clinical trial, what are the latest treatments coming down the pipeline, and how do I hang on to that hope? Do you see that?
Yes, I do, and that's a tricky space in psychology because on the one hand we want people to have hope, no question. We also have to be almost fairly constantly reminding everyone that everybody's cancer experience is individual and that you can have almost the same oncological presentation, almost the same demographics, and you can have a completely different outcome. And there doesn't appear to be a lot of like logical scientific rationale to that, but that is the reality. So sometimes when people will come in and be like, I've got a friend or I know of and I want access to that or whatever, it's like, yes, like absolutely, and that needs to be investigated and explored, but it kind of has to be done with a little bit of tempered enthusiasm, because if your expectations are allowed to go there, and then you discover because of your particular presentational circumstances that you're not able to access it, or that your experience is not like that of your friend or your other person that you know, or wherever you got that information, that discrepancy between expectations and experience, we call that a negative discrepancy, and the bigger that gap is, the more psychological distress there is. So I'm always about like, yeah, like let's investigate that, but let's keep our expectations modest, and then always better to have low expectations exceeded by experience rather than high expectations dropped by experience. Get that?
You also mentioned, you touched on at the start of the session, the supports and things that people can do. Not always people can access a psychologist or have a one-on-one psychological appointment if that's what they're seeking. Apart from the podcast series, and I recommend that there's some great information in here, and support that people can use. What are some of the other things that they can use? I know we've got the breast care nurses here too.
Yeah. So the thing about a lot of psycho-oncology experiences is that they don't often feel or look the same as high-level psychiatric or psychological disorders. So for a lot of people living with distress, cancer-related distress, they can feel like, oh, my stuff's not really bad enough to go and see a psychologist, or I'm not really nutty, don't really need to see a psychologist. And up until last year, certainly, 35% of Australian psychologists had their books closed or you couldn't get into them for 6 months. So we need to be mindful that it's not easy to access a psychologist, and particularly so in regional areas. The podcast is good, and I don't say that because I don't get anything out of it other than feeling good in my underpants, but it's a good resource, and we've got 121,000 downloads to endorse that. So I would recommend the podcast as a way of feeling like you can make sense of some of the stuff that you might have been going through, and it's a great resource to share with family and friends as well. Breast care nurses are amazing, and if you're fortunate enough to have access to one, or if you now can get access to one, then definitely do that, because it's not just the fact that they really understand breast cancer, but it is their accessibility. You can get to them, I think, by a mobile phone, which is rather heavenly, because I know most oncologists and surgeons aren't like that. So definitely that. Good GP. Again, I appreciate that in the regional areas that's not, if you get a good GP, they could be great, but also a lot of GPs come and go in regional areas. There are online resources, but it does take a bit of Googling, and I would always refer you to go back to like tried and true sources of good information, like the BCNA website, where things have actually been properly reviewed, so that your risk of maybe engaging with something that's not helpful is greatly reduced. If you... Again, it's horses for courses. If you feel like I just want to do one thing and I can't get access to a mental health clinician, I know this sounds weird coming from a psychologist, but mobility of some sort. When you're living with metastatic disease, hardcore exercise sometimes isn't possible, especially those people who've got a broken hip. But any sort of mobility. You saw what Neil was doing before with the lymphatic exercise. Well, I was doing that too, and I was thinking, this stuff works for everything. It is the silver bullet. So mental health wise, I know sometimes my clients will say, you're a psychologist, but you're telling me to exercise. And I'm like, yeah, if it's going to be medication, as in antidepressants, and you don't want those, and not a lot of people do, if you're not going to do that, then exercise. It is the silver bullet.
Terrific. Please join me in thanking Charlotte Tottman.